And go. You can go ahead, Tiffany.
I know it was in my way, the little box to allow it. Obsessive compulsive disorders by Kennedy Johnson and Tiffany Neal. You can switch it. What is OCD? OCD is a chronic mental disorder that causes significant emotional distress. It has a potential to last a lifetime in all populations. So it doesn't discriminate regardless of culture, race, age. It can affect anyone. The main characteristics of OCD are obsessions and compulsions that are strong and repetitive enough to impact anxiety and one's daily functioning. Recently, OCD has been shown not to be as rare as it was previously thought. And it's actually comparable to panic disorder and appears 3 times as much as schizophrenia. OCD has a cycle. So it'll start with an obsession about something, constant thoughts in your head, very intrusive. And then that'll give you some anxiety. And the anxiety will increase until the compulsion. So like if you have a need to wash your hands, you'll have anxiety until you wash your hands. And then the compulsion is met with relief. So after you wash your hands, you feel relieved. And then it starts again and you get obsessions. Okay, the case of John Doe. John Doe is a 21-year-old white heterosexual male college student. No. When John was 16 years old, his mother underwent a heart transplant, leaving her immunocompromised for almost 8 months. During that time, any infection could have been fatal. So his family took extra precautions to keep her environment sterile. It became normal to regularly wash your hands and avoid germs. But gradually, his behavior continued to increase. And then, during the pandemic, he realized his personal fears of contamination, not only related to not wanting to harm his mom. Anxious thoughts started to increase. His thoughts and behaviors continued to increase even after the pandemic was over. After graduating at 18, he moved into a shared apartment where he took online college courses and worked remotely from home. He never told anyone about the negative effects and started isolating himself away from others that did notice and started to comment on his behaviors. He knows it's not normal, but can't really stop it and is always thinking about it. Now he washes his hands constantly and does not touch anything that is not without gloves, that is not his without gloves. On average, he washes his hands about every half hour for 3 to 5 minutes each time. His hands are flaky and cracked due to the dryness and chemicals from constant washing. He rarely finds relief from the overwhelming thoughts about germs and dying from infection. He is almost unable to leave home now from the intense fear of contamination. And the only time he socializes is through a computer. The criteria for diagnosis that he has met, he meets all of the criteria, having both obsessions and compulsions. More than an hour a day is spent on obsessions and compulsions, experiences significant distress and impaired functioning in social areas. OCD symptoms are not due to drug use or other medical conditions. The distressful symptoms are not better explained by OCD-related or other disorders and are representative to the specific OCD dimensions of contamination, obsession, and cleaning compulsions. Specified, and is also specified with good insight, and it's his OCD is not tick related. This is a referral letter that was written for medication treatment. So, yeah, that's good. Obsessive and compulsive and related disorders. So OCD is different from the OCD related disorders. They're body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, excoriation, which is skin picking, substance or medication induced OCD, OCDRD, which is obsessive compulsive and related disorders due to another medical condition, other specified OCRD, and unspecified OCRD.
So these are the FDA approved medications when it comes to OCD. You have clomipramine, other known as anafranil, fluoxetine, which is Prozac or Serafrim, fluvoxamine, which is Luvox, paroxetine, which is Paxil, sertraline, which is Zoloft, citalopram, which is Celexa, and escitalopram, which is Lexapro. When it comes to these medications, they all have different starting doses, which is what the doctor will put you on in the beginning to see how your body will react to the drug and how your body chemistry will work with it. The starting dose for sertraline is 50 milligrams a day. Paroxetine is 20, fluoxamine is 50, fluoxetine is 20, citalopram is 20, escitalopram is 10, and clomipramine is 25. The target doses for those following are 200 milligrams. These are the max dose that you can take. 200 milligram, 60 milligram, 300 milligram, 80 milligram, 40 milligram, 20 milligram, or 250 milligram, and that's all per day. Adverse effects of these medications, which, I mean, obviously all medication comes with effects. The SSRIs, which are the ones other than chlormipramine, the effects are GI stress, agitation, insomnia, increased sweating, sexual dysfunction, and or serotonin syndrome. The side effects of chlomipramine is dry mouth, blurred vision, constipation, urinary retention, weight gain, sedation, orthostatic hypotension, serotonin syndrome, arrhythmia, and or seizures. Other uses of these same sort of medicines can be for depression and anxiety. For as far as drug interactions, there are found to be interactions between SSRI and tramadol. Tramadol is used for um sleeping, I believe, or pain. Beyond its actions on the opioid system, tramadol blocks serotonin uptake and increases its basal release. It therefore increases serotonin availability, as do the recommended first-line treatments in OCD, the SSRIs, and the other antidepressants considered second-line treatments in OCD, which are clomipramine and venlafaxine. So you don't want to take those drugs together because it's basically just the same thing, and it could just be a hyper release of serotonin. Relevant issues whenever it comes to pregnancy. While SSRIs are thought to be relatively safe, they are not without drawbacks. SSRI use has been linked to early delivery and smaller babies, but it is unclear what impact the severity of the underlying depressive or anxiety symptoms has on these outcomes. So, as a lot of you may know, like if you are pregnant, like I have a client that is pregnant and she's not able to take any of her mental health medicines because of this. So, this wasn't a surprise to me. Recently, OCD has been shown to not be rare not to shown not to be rare as previously thought and found comparable to panic disorder and up to 3 times as prevalent as schizophrenia. ERP for OCD, which is a type of psychotherapy treatment. Exposure and response prevention, which is what ERP stands for, is a first line treatment for OCD. ERP is a form of cognitive behavior therapy that involves providing psychoeducation to the patient, helping the patient confront fears or discomfort related to their obsessional thoughts, which is exposure, which is the exposure part of ERP, and having the patient resist performing compulsions, which is the response prevention part. Patients can be exposed to actual situations, in vivo exposure, imagined situation, which is imaginary exposure, or the physical sensations associated with anxiety or discomfort, interoceptive exposure. The goal of ERP is to challenge how a patient responds to distress and to eventually learn that feared stimuli are safe. In this review, we will discuss the theoretical background of ERP factors related to the efficacy and effectiveness of ERP and treatment utilization and dissemination. So that was from an article, a journal article I found on ERP. And the link is at the end of the slides.
Okay, so a double-blind, placebo-controlled medication study was performed. A double-blind randomized trial with placebo control was conducted to test amantadine as an adjunction therapy method for moderate to severe obsessive compulsive disorder treatment. So whenever something's in an adjunction method, it means that it's given after the other medication. It would have significant differences if it was given before. The study was conducted throughout a 12-week trial that screened 140 patients and chose 106 of them for the study. Some were excluded and some dropped. Then they were split into 2 groups of 53 patients each. One group was given fluvoxamine and amantadine. 51 patients completed that trial. The other group was given fluvoxamine and a placebo, and 49 patients completed that trial. The study used the Yale Brown Obsessive Compulsive Scale to measure reduced obsessive and compulsive symptoms. Throughout the 12-week trial, no differences were seen within the first 2 weeks. However, at the 4-week mark, there was reduction seen, and significant reduction was shown between the 10th and 12th week. The trial showed the potential benefits of amantadine when combined with fluvoxamine. And those are some of our references.
Yeah, these are just our references. These are more references. And that is the end. The questions will be separate and sent to Dr. Gastineau.